I'm Gary Stoner from the University of Rhode Island. I have been working in the area of attention deficit hyperactivity disorder for more than 30 years now. And so I have quite a bit of experience that I would like to share with you, and I'm sure that you all have quite a bit of experience to share as well. What I'm going to do and what I was asked to do for today is to talk about assessment and diagnostic issues relative to children with attention deficit hyperactivity disorder, in particular with a focus on issues in a school setting and what kinds of activities might we engage in relative to assessment and diagnosis in a school setting. Okay, so I'm going to talk about those issues and that focus and kind of walk through the whole set of issues relating to conducting a diagnostic evaluation from a school perspective. And in addition to that, we could kind of throw out this whole set of PowerPoints and presentation and talk about all of the issues that go along with working in a school setting around attention deficit hyperactivity disorder. And those include things like collaborating with community-based physicians, working with parents and communicating with parents about how the school perspective might be a little different than a community-based psychologist perspective and a pediatric perspective. It includes issues that relate to helping parents understand what the school can do in terms of supports for students with ADHD, as well as diagnostic and assessment work around ADHD. It also has to do with issues around medication and medication management. And there's broad issues that I'll touch on this morning as well as this afternoon when I talk about school-based support for children with attention deficit hyperactivity disorder. So we'll kind of touch on those issues, and you can raise those issues and ask questions or participate by making comments as you would like. And I'm going to try to talk primarily about school-based issues, but we'll invariably branch out into talking some about community-based issues as well. Okay, so with that, I'm going to do a little bit of an overview, give you some guidelines and principles, talk a little bit more about basic issues in understanding ADHD. And the main reason for this is to establish a shared understanding of these issues, as well as to talk about things that I think need to be communicated in the context of schools and schooling. When I talk about these issues, I think one of the things we have to understand as a primary foundation is that attention deficit hyperactivity disorder, ADHD, has and always has been primarily in the realm of pediatricians and child psychiatrists. It has not been primarily the purview, per se, ADHD, of people in schools. However, the support of children with these types of problems has been a primary issue for people who work in schools. But we have had this tenuous relationship with the assessment and diagnosis and identification part of ADHD. And that creates a number of different issues for us. But what we know about ADHD are these things, that it's a set of behaviors that reliably co-vary. It's usually a chronic problem that occurs over time. We used to believe that ADHD went away with adolescence. We now know that that's not the case, that the symptoms change a bit and some of the externalizing and problematic symptoms dissipate around adolescence. But problems persist over time, over the course of the lifespan, that this is a problem that's responsive both short-term and long-term to pharmacological interventions as well as to behavioral or environmental manipulations, and that treatment effects what we do in school, and we see this all the time, that we can gain control over certain types of problems in certain settings, but if we don't work really hard to generalize those or to program for generalization and maintenance, that those treatment effects will dissipate very rapidly. So if we train or teach in one setting, in the school setting, those effects aren't necessarily going to carry over from classroom to classroom or from classroom or school to home. So we have to think about multiple setting supports and multiple setting interventions. And ADHD tends to run in families and is associated with significant family distress. The reason that this issue of tending to run in families is important is that one of the primary places we turn for supports and for information about attention deficit hyperactivity is to parents. And oftentimes we will be working with parents who also are experiencing significant issues with attention and impulsivity and so on. And that condition may color their perspective of how their child is functioning. So we kind of have to be aware of not only the child, but how is the family functioning, what is the functioning like of the parents, and we have to be able to talk about this. That's why this, as I said, as a foundation, these are issues, when we talk with parents about ADHD tends to run in families, so when we're doing assessment or communicating with parents, one of the things that we have to be able to do is to look parents in the eye and say, is this a type of problem that either you or your husband has experienced during your childhood or are experiencing now? Or are there other people in your family who have experienced this problem? And if so, how might that affect your perspective of your child's functioning, and how might it affect your perspective of various treatments? Okay, so I'm not putting all these things up here so that we can have all this factual knowledge and say, okay, here's all the things that we have to know. Here's some things we need to know, and it's important because it affects the way we should be acting as professionals in doing the work that we do and relating to families. Okay? How many of you have worked with children around ADHD who had parents who were experiencing significant difficulties with attention and impulsivity themselves? I see lots of hands raised and heads nodding, and so it becomes an issue also not just of supporting the child, but then thinking about what's my family support going to look like in order to be effective. And that creates a sort of a double challenge for us. Okay? Some things that we don't know. We don't really know the etiology, although it seems to be that ADHD is a poor fit, a biological predisposition to having a poor fit between school environments and demanding home and community environments and children's approach or children's ability to interact with those environments. We don't know exactly what the association is with learning disabilities, although it seems that if we talk about this as a chicken and egg question, the ADHD tends to come first, it seems. The support seems to suggest that the ADHD causes learning problems in school, or attentional problems cause learning problems in school. We don't really know why medication works for some children and not others. We don't know exactly what the best methods for academic instruction are, but it's a pretty good guess that explicit instruction with lots of individualized supports is a good starting point. Again, I'll talk about that this afternoon. We don't know a lot about preventing ADHD from an antecedent or proactive perspective, although we have some evidence that's starting to emerge. Long-term evidence is very spotty, and we don't have good predictors of response to intervention, although now my colleague George DuPaul at Lehigh has begun to do some work on functional assessment of children's behavior with ADHD, and has been able to demonstrate with young children at least that if we, even with children diagnosed with ADHD, when we identify the functions of some of their externalizing behavior problems, we can predict that function-focused interventions can be more effective than non-function-focused interventions. So that's where we have a blend of both a diagnostic model and a functional model of support. So we're beginning to see blending of evidence from different perspectives on this issue as well. Some myths or things that we still hear and still talk about with people, that ADHD is a new disorder. I never had this when I was a kid, or we never had that problem when I was in school. And so this is another issue that we have to talk about with people, that while the name has changed over time, we have had children presenting with these types of problems for a very long time now. ADHD is meaningless. That's another thing that people will say. Now, there might be a kernel of truth in some of these things. Now, one of the reasons why we talk this garbage pail, it's a pretty terrible term, I know. Why might people, talk about ADHD as meaningless or having little meaning? One of the problems with ADHD is there's so many different ways that people identify children with ADHD, from a 10-minute visit in a pediatric office to a 14-hour evaluation by a child psychologist and psychiatrist in a multidisciplinary team in a hospital setting, to a school-based diagnostic evaluation, and everything in between, that people will have, that in reality we have many, many children identified with the same disorder in many different ways. And so people get confused about, is there really meaning in this disorder? And we could talk about that for hours, but we're not going to. We can't do that. But that's one of our problems, right? And we have to talk about that too. Okay, so we want to work to make ADHD less subjective and more reliable. We have to continue to dispel this idea or the myth that medication response is a diagnostic tool. Okay, so as a postdoctoral fellow many years ago, I worked at Johns Hopkins University Medical School with psychiatrists and pediatricians in training. I was a postdoctoral fellow in psychology. When I was asked to give a talk to pediatricians and psychiatrists, child psychiatrists in training, this is something that they believed. Okay, so there are other things that they were taught that were inaccurate. Okay, so if we're working in the community with psychiatrists, with psychologists, with pediatricians, we're going to have conversations with those folks about their perspectives about ADHD, their perspectives about different treatments, and we're going to have some discussions about what do we know and what do we not know. Okay, but medication response is not a diagnostic indicator. Many children with many different types of disorders, or without any disorders at all, their behavior will improve at low doses of stimulant medication. Okay, their attention will improve, their focus will improve, and so on. It is not indicative of having ADHD.